This program is brought to you by Emory University.
Good morning, everyone. We'll get started. Our speaker this morning, as you can see, is Dr. Ann Young. Ann is one of our third-year fellows, first-year clinical fellows, but third-year fellows in our clinical investigator research track, and did medical school at Mercer University, then came to Emory for residency in internal medicine, spent a couple years as a hospitalist at Grady. Was it a couple years, Ann? Maybe one or two as a hospitalist?
1 or 2, yes.
1 or 2 years as a hospitalist at Grady, and then entered our clinical investigator research track, did research with Doctors Kayumi and Vaccarino. And she is going to talk today about a topic near and dear to my heart, hypertrophic cardiomyopathy and pregnancy. Ann.
Okay. Thank you, Dr. Williams. Okay. I'm going to stop my video so I can follow along with my presentation easily. So good morning, everyone. The topic of my talk today is about hypertrophic cardiomyopathy and pregnancy. Okay. So I will start with a brief case presentation, provide an overview of hypertrophic cardiomyopathy, including background, clinical manifestations, pathophysiology, and diagnosis. Then we'll discuss presentation and management of Holcomb, specifically in pregnancy. So we'll begin with a case presentation. A 23-year-old female, G1P0, 37 weeks, presents at cardiology clinic for coordination of care with history of HCM and gestational hypertension. Prenatal care was initiated in St. Thomas, and then she was transferred here to Grady for tertiary care. She was diagnosed with Holcomb at the age of 9, no family history. Patient father was unsure if the patient had genetic testing at the time of diagnosis. She was occasionally symptomatic with palpitations and presyncope with exertion. However, she has been asymptomatic throughout pregnancy. Pregnancy has been complicated by gestational hypertension, diagnosed 2 weeks ago when she came in with headache and nosebleed. Family history is significant for hypertension, and she's currently on metoprolol 25. Physical exam with vital signs as above. Exam otherwise unremarkable with normal JVD, notable for a loud systolic ejection murmur, harsh crescendo decrescendo loudest at the apex and radiating to the left lower sternal border. There's no S4. Labs were unremarkable except for an elevated BNP of 1128. This is her EKG, which shows LVH with abnormal Q waves in the lateral leads and left atrial enlargement, which is typical of HCM. Other associated EKG changes can include marked T waves, inversion in lateral precordial leads. More typical of apical HCM, which is not seen here. This is a parasternal long axis view of the patient's echo, which shows a severely thickened septum of 3.4 centimeter and LV posterior wall 1.7 centimeter with severe asymmetric LV hypertrophy. The LV cavity, as you can see, is small. Again, the thickened septum and small LV cavity. There is systolic anterior motion of the chordal apparatus and the mitral valve. The SAM is predominantly chordal, which accounts for the modest increase in the intracavitary gradient, and there's mild subvalvular aortic stenosis. The peak mean AV gradients here 26 and 17 at rest, and with Valsalva it increased to 47 over 27, with 47 peak and 27 mean. So let's talk about ACM in general. It's an autosomal disorder affecting the cardiac sarcomere proteins with variable age-related penetrance. It is the most commonly inherited cardiovascular disorder with 0.2% prevalence in the general population. It's characterized by increased LV wall thickness not caused by other systemic, metabolic, or secondary causes of LV hypertrophy, such as hypertension or athlete's heart. The hypertrophy is often asymmetric, involving almost any myocardial segment, most commonly in the basal interventricular septum, most commonly diagnosed in young adults 23 to 35 years of age. An underlying genetic cause is only found in about 1/3 of patients, with the most common mutation being the MYH7 and the MYBPC3 gene. The offspring of the carrier has a 50% chance of inheriting this disorder. The mutation affects the myosin and actin binding chains, causing excessive binding with increased cross bridges, leading to an increased contractility and impaired relaxation. Normally, about 40 to 50% of myosin chains are in a resting state. However, in HCM, only 15% are in a resting state. This leads to disorganized myocytes with a whorling and fibrosis pattern seen on histology um, in patients with ACM on the left compared to the normal myocardial tissue on the right. The hypertrophy commonly affects the interventricular septum in the proximal section or throughout the entire septum. About 10% occurs in the apex, and another approximately 10% can occur with diffuse thickness throughout the LV wall. Hypertrophic cardiomyopathy is considered diagnosis when there is a thickness of greater than 15 millimeter of one or more LV segment on echo, cardiac MRI, or CT. Septal or posterior wall thickness ratio greater than 1.3 in a normal tensive patient, or 1.5 in a hypertensive patient, or first degree relative with unexplained wall thickness greater than 13 millimeter. Other diagnoses that can mimic ACM includes chronic hypertension, cardiac amyloid, athlete's heart, and valvular AS. The clinical manifestation of ACM are caused by dynamic subaortic obstruction, and symptoms can occur in both those with and without obstruction. While the majority are asymptomatic, among those who are symptomatic, exertional dyspnea is most common, followed by atypical chest pain or angina. About 50% reports presyncopal symptoms and other with syncope symptoms. Palpitations secondary to arrhythmia such as PACs, PVCs, AFib, A-flutter, SVT are common. Typical congestive heart failure symptoms secondary to increased filling pressures and myocardial ischemia can be rare. Sudden cardiac death occurs in about less than 1%. The characteristic exam findings include the rapid upstroke of the carotid pulse or bifid carotid pulse, which declines in mid-systole as the gradient develops. Possible prominent LV lift, a palpable atrial beat, prominent A wave, and S4 can be found in young adults. The systolic through along the left lower sternal border. Characteristic murmur is a harsh diamond-shaped systolic murmur at the apex rating to the left lower sternal border. And sometimes the paradoxically split S2 due to prolonged LV ejection time and the presence of outflow obstruction. This table shows the different maneuvers that can affect the intensity of the gradient and murmur. Those such as Valsalva and standing can decrease the LV cavity as well as pre and after load, and therefore increase the gradient and murmur intensity, while squatting increase the LV cavity and pre and after load, which in turn decrease the gradient and murmur intensity. The clinical manifestation of ACM are by multiple mechanisms, including LV outflow tract obstruction, diastolic dysfunction, myocardial ischemia, mitral regurgitation, and arrhythmias. And the postulated mechanisms for myocardial ischemia are due to hypertrophy, possibly causing partial obliteration of the intramural coronary arteries, also possibly due to inadequate number of capillaries for the degree of LV mass and increased myocardial oxygen and consumption supply-demand mismatch. However, these are only theories at this time, and it hasn't been confirmed yet. So LV outflow obstruction occurs in about 2/3 of patients, and it is associated with higher morbidity and mortality. The LV obstruction is produced by the systolic anterior motion of the mitral valve, causing subaortic stenosis. which can worsen in certain conditions that decrease preload and afterload or increase contractility. And dynamic stuff stenosis as mentioned. And so this is a live view of the systolic interior motion of the mitral valve leaflet, creating the LV outflow tract obstruction. The mitral valve is drawn toward the septum because of the lower pressure that occurs as blood is ejected at high velocity through a narrow outflow tract called the Venturi effect. And then the mitral valve is also pulled against the septum by contraction of papillary muscles, which occurs because of the valve's abnormal location and septal hypertrophy. So the two motions cause a hydrodynamic drag and pushing force of flow leading to mitral regurgitation. This broad dagger shape shows a typical LV outflow tract obstruction with late peaking gradient. And diastolic dysfunction can occur due to impaired relaxation of the hypertrophy cardiac muscles with decreased compliance from disorganized cellular architecture, scarring, or fibrosis. Diastolic dysfunction can account for symptoms of exertional dyspnea, which with increased filling pressures leading to increased pulmonary venous pressures. Currently, there are several modes of methods for diagnosis of Holcomb. Echocardiography is currently the main mode of method used to diagnose HCM and is used to measure wall thickness and LV outflow tract obstruction and gradient. Stress testing with Valsalva is indicated for those with normal LV outflow gradient to assess for possible dynamic obstruction. TEE can be used to define the mitral valve abnormalities or help to guide surgical interventions. And finally, cardiac MRI is used to help identify areas of hypertrophy not well visualized on echo for more accurate wall thickness. Can be used to differentiate HCM from other causes of LVH, such as well as patients with apical aneurysm, which can be associated with higher risk of ventricular arrhythmia, stroke, and then it can also identify extensive late gadolinium enhancement of the LV myocardium, which can be associated with increased risk of sudden cardiac death. CT scan can be used in the absence of cardiac CT or insufficient echo, and genetic testing is reserved for those with unclear causes of LVH. Now let's shift gear and talk about HCM and pregnancy. The hemodynamic changes in pregnancy leads to increased blood volume and LV size, which can decrease the LVOT gradient, offsets the adverse effect of a drop in peripheral vascular resistance. The increase in blood volume can increase LV filling pressure, and the increase in heart rate in pregnancy can also shorten the diastolic filling time. Post-delivery changes such as tachycardia, increased venous return after removal of IVC compression by fetus, and redistribution of the extravascular fluid can lead to elevated filling pressures, volume overload. Overall, most patients with HCM can tolerate pregnancy well. However, due to the pathophysiology of the disease discussed earlier, various complications can occur based on limited case report data from the Registry of Pregnancy and Cardiac Disease. Among 60 pregnancy in women with HCM, with 42% having obstructive HCM, complications can include arrhythmias, congestive heart failure symptoms, early termination of pregnancies resulting in fetal loss in 3 cases, and less than 1% with premature delivery. 80% of neonates were diagnosed with inherited HCM. And maternal death is rare, about 0.05%. Most of the complications occur in the 3rd trimester or first weeks postpartum, and this usually is due to heart failure symptoms as well as ventricular arrhythmias, and in the commonly in the 3rd trimester and first week postpartum. Fetal outcome in most cases does not seem to be affected by maternal HCM. The incidence of premature birth is similar to women without HCM, and fetal mortality is similar to the general population. TTE is definitive and safe in pregnancy and can be used with Doppler to assess for LVOT obstruction and MR in pregnancy. Cardiac MRI is safe after the first trimester. However, gadolinium can cross the placental barrier, and therefore risk to the fetus is unknown, and therefore this is not currently recommended for use routine diagnosis in pregnancy. It is recommended that a detailed risk assessment is obtained prior to conception with inclusion of family history, physical exam, EKG, echo, baseline serum BNP level, cardiac MRI, and Holter monitor if needed. Current AHA guidelines recommend discussion of risk and potential complications, including effective disease on the safety of pregnancy for both mother and fetus, risk of medications, and the likelihood of transmission of HCM to child. Those with moderate or severe symptoms of heart failure with New York NYHA class 3 or 4 symptom should be advised against pregnancy. Currently, the indication for ICD are similar for both pregnant and non-pregnant women with HOCMs. Primary ICDs recommend for those with a positive family history of sudden cardiac death, those with recurrent syncope, LVH greater than 3 centimeters at any site in the LV, abnormal blood pressure response in exercise, and non-sustained VT and Holter. And secondary degree risk factors including AFib, A-flutter, high LVOT gradient, gradient 50 at rest, evidence of ischemia during exercise, as well as marked fibrosis on cardiac MRI. So the general principle of management of HCM during pregnancy is as recommended by the ESC guideline, which I will go into detail in the following slides. Mainly for asymptomatic patients, no prophylactic treatment is needed. Continue beta blockers if already on it, and start beta blockers for any new symptoms. Close monitoring of hemodynamics during the later stages of pregnancy and peripartum is recommended. And in patients with resting or provocable LVOT obstruction, avoiding factors that can decrease afterload, preload, or vasodilation, and C-section only in cases of severe heart failure. For treatment of symptoms, selective B1 beta blockers is class 1 indication for angina or dyspnea for both obstructive and non-obstructive ACM, and it's recommended to titrate to resting heart rate 60 to 65 for symptoms control or 20% reduction in heart rate. It is important for those on high-dose beta blocker to have close monitoring for fetal bradycardia or fetal growth retardation. And premature uterine contraction with non-selective beta adrenergic agents can occur. Calcium channel blockade like verapamil can improve LVOT obstruction and cardiac symptoms via negative inotropic effects. And disopyramide, a type 1A antiarrhythmic agent, has negative inotropic properties, which can decrease the pressure gradient. Surgical myomectomy and septal ablation currently not recommended during pregnancy, but have resulted in successful pregnancy based on limited case report. For arrhythmias, Holter or loop monitor during pregnancy for those with symptoms is recommended. Low molecular weight heparin in the first trimester if anticoagulation is needed, and then recommendation to switch to vitamin K antagonists in the second and third trimester, followed by low molecular weight heparin after 36 weeks. Beta blockers are recommended for rate control, and flecainide is the drug of choice for pill-in-the-pocket approach. Electrocardioversions recommend for those with hemodynamic compromise. As for the mode of delivery, vaginal delivery is preferred. Assisted delivery may be used to shorten the second stage of labor. C-section can be used, but are most commonly reserved for those with obstetric indications, severe LVOT obstruction, or currently on oral anticoagulation at the time of delivery, or having severe heart failure symptoms. The goal of labor and anesthesia is to minimize LVOT obstruction by maintaining adequate filling pressures and systemic vascular resistance. So it's recommended to avoid epinephrine for local anesthetics, avoid prostaglandins given the vasodilatory effects, avoid tocolytic agents with beta adrenergic stimulating activity. Epidural anesthesia is generally safe with careful maintenance of the intravascular volume and avoidance of aortocaval compression. For hypotension, it's recommended that we use phenylephrine for pure alpha adrenergic effects. And preloading before induction is recommended to maintain LV filling pressure and stroke volume. Finally, oxytocin should be given via slow IV titration to minimize vasodilation. And it's recommended that there is close continuous hemodynamic monitoring 24 to 48 hours postpartum for signs of hypervolemia. So back to our case and plan. These are our recommendations for this patient with severe HCM and evidence of LVOT obstruction. For anesthesia, we recommend avoidance of fentanyl for vasodilation and hypotension. And then I recommend planned epidural to allow for slow dosing to avoid hypotension, and then decrease labor pain to avoid minimize tachycardia with invasive blood pressure monitoring. We also recommend avoiding large doses of neuroaxial anesthesia to avoid the vasodilation. Induction was scheduled. We recommend avoidance of Pitocin for as long as possible to help maintain fluid balance, and terbutaline was contraindicated. For delivery, we planned for vaginal delivery with assisted second stage to avoid hemodynamic changes of tachycardia and possible decreased venous return with Valsalva. C-section can be performed safely. However, we would recommend slowly dose epidural. And then certain medications to avoid, including terbutaline, fentanyl, diuretics, as well as QT prolonging meds, most notably Zofran and zithromycin. And then this is the patient's hospital course and induction timeline. On December 9th, the induction was started. After epidural, she became tachycardic and had decreased venous return as she was started on phenylephrine drip. Limited TTE shows worsening LVOT obstruction with peak mean AV gradient 79/44 during labor with moderate MR. On December 10th, she underwent elective C-section with delivery of a healthy baby boy, and she was transferred to the CCU afterward for tachycardia and SVT requiring esmolol drip and phenylephrine for vasodilation with anesthesia. On December 11th, she was transferred out of the ICU, weaned off drips. She was placed on tele given episodes of PVC and non-sustained VT. And repeat TTE shows continued modest, slightly higher outflow tract gradient compared to baseline. On December 15th, she was discharged on home Topral 100 daily with depot for contraception and a postpartum hemoglobin of 8.7. She subsequently returns to St. Thomas for her postpartum care. So again, I would like to thank the following people for help with providing materials for this presentation, as well as feedback, and for the fellows and attendings involved in this patient's care. And now I will take any questions that you have.
Thank you, Ann. Very good case. I'll just throw a couple comments in before we open it up to the group. Yeah, my experience with these patients is sort of similar to what you guys experienced with this young woman, is that generally speaking, these patients do well with pregnancy, except when they don't. And when they don't, it sometimes can go really unwell. And it's a little bit hard to predict. I mean, you're right. I mean, the patients that have more severe disease and are more symptomatic are clearly at higher risk to have more problems, particularly with heart failure or hemodynamic instability. The patients that are very, very symptomatic, that have high LVOT obstruction, are patients with bad LV function at baseline. Obviously, those patients are at higher risk. There's a subset, though, of these patients that just tend to have like a flurry of arrhythmias during pregnancy. And that is, in my experience, has been more difficult to predict who that's going to happen to, whether it's supraventricular arrhythmias like AFib, or even we've had patients that just start having sort of malignant ventricular arrhythmias as well. And again, that one seems to be more random. The other error that we'll see sometimes with these patients is that a lot of times they get treated, by anesthesia or obstetrics or whoever's caring for them, sort of peripartum, like patients with high-grade valvular stenosis, like a mitral stenosis or an aortic stenosis patient, where they're really afraid of volume resuscitation in these patients. And we have to continuously remind them these patients can actually handle volume relatively well. In fact, often do better when they run, sort of a little wet on the wet side. And so that's the thing we will constantly harp on, anesthesia and obstetrics, and those involve sort of during labor, is it's okay to give them fluids, run them wet, because, probably better to be a little volume overloaded in these cases than volume depleted, because they just do not handle volume depletion well, whether they're obstructive or not. They need that sort of preload, or they can get real hypotensive real quick. And, particularly these obstructive patients, a little more volume actually can help the obstruction slightly. Sure, they can have diastolic heart failure, or systolic heart failure, whatever the case may be. But that's a little bit unusual, and that's something that can be sort of treated after the fact, with a little gentle diuresis. I tend to see it's much more likely these patients get in trouble when they get volume depleted as opposed to when they get volume overloaded, in my experience in these cases. So if you're ever involved in these cases, don't be afraid to give them volume, during labor, delivery, that sort of thing, particularly when they're getting anesthesia and pain medications, and they're obviously losing volume, bleeding, et cetera. You have to be aggressive with volume resuscitation.
Robbie, it's Stan.
Stan, go ahead.
Just a quick question. In this particular patient, she did have ventricular tachycardia, at delivery time and around delivery time. Would that just mean to you that you have to work her up afterwards, or is that enough indication to recommend, an ICD therapy?
Yeah, that's a good question. I guess it sort of depends on the rest of her picture. If there were, other risk factors, I mean, I don't know. I mean, whether you can sort of dismiss VT in the peripartum when you're getting, when you're getting vasoactive agents to increase your blood pressure and all this sort of stuff, whether you'd sort of write that off. I mean, certainly it's something to be considered. You'd want to take it in sort of the greater context. I'd be hard pressed if the patient was overall low risk and had no other risk factors and just had a little bit of VT peripartum. I'd be a little bit reluctant to probably just, put a defibrillator in for just that. But certainly it wouldn't be unreasonable. But again, I would probably sort of take the broader clinical context into account.
Gotcha.
Hey, Dr. Eames, I have a question for you.
Go ahead.
Is there something you have to watch out for in the postpartum period? Are they at an increased risk of, arrhythmia or whatever for X amount of weeks, or anything that you know of postpartum?
And did you see anything about postpartum
Yes.
complications?
So based on the registry of pregnant women with cardiac disease, it shows that the most complication occurs in the third trimester and postpartum period. So, and then those complications are commonly due to arrhythmia or heart failure symptoms. So it
Did that registry say how long, like how many weeks postpartum? Was that
I think I don't know the exact time frame, but it's like peripartum, postpartum. Let me just double check to confirm for you.
But I would agree with
Let
that.
me,
It's
yeah, let me,
go ahead.
this is, hey, Robbie, you go ahead.
No, Mon, you go ahead.
So I would echo what Robbie said earlier about volume resuscitation and keeping these patients wet. Realize that pregnancy is a huge hemodynamic burden on a pregnant patient. The cardiac output has to double under normal circumstances. The cardiac output plateaus at around the 6-month mark and then sort of levels off. Now, that also means that the volume, circulating volume, is also significantly higher. These patients, as Robbie mentioned, tends to not like being dry. And so you have to fill up the tank. However, right after you lose the placenta, after delivery, there's a rapid re-equilibration that must occur. And these patients and other patients with congenital heart disease and heart conditions in general tend to be at risk of pulmonary edema in the first few days, 2 to 3 days postpartum. And I've seen practice vary significantly. Some patients BNP can be a helpful marker to sort of help with your volume assessment, but that's not completely reliable. Data are mixed in this era. But I think, I would err on wet in the delivery period and a little bit more aggressive with diuresis in the postpartum period in general. Obviously, this is something that is a bit of a moving target. And if you over-diurese, you have to give fluid, and sometimes it's a bit of a seesaw type thing that you have to sort of change your mind pretty quickly, depending on how fragile the hemodynamics are.
I would agree with everything Mon just said. And to answer Marcelo's question, you will see arrhythmias postpartum, I suppose. Those tend to occur, in my experience, more during pregnancy. I mean, they can certainly occur postpartum as well. But like Mon said, if someone's going to go into sort of heart failure, it tends to be in the week or two. So a lot of times they get sent home a couple days postpartum, and they're doing great. And then we get a call like within a week of them getting home, like, I feel terrible. My ankles are swollen. I can't breathe. Well, and we got to start them on a little bit of diuretics, which is okay. So a lot of folks that aren't generally on diuretics might need a couple weeks of diuretic therapy in the immediate postpartum period. So that's the thing we see the most. Dr. Dicker has typed in, and answered it. 5% fetal mortality. Yeah, okay, right. And
Apologize, I think that was a mistype, but it's 0.5%. And to clarify Marcelo's question earlier, so arrhythmia and heart failure symptoms in the third trimesters are common, and then in the first week postpartum is when you see the symptoms of like more congestive heart failure, like volume overload, as Dr. Jokadar and Dr. Williams have mentioned earlier. So within that first week postpartum.
other questions?
Can you hear me, Robbie?
Yeah, we can hear you.
Okay, Ann.
Yes.
So my question is, as you have thought about this, and you can consult Robbie, how do we make the diagnosis? Granted, once they get referred to a cardiologist and all that, how do you think we usually make the diagnosis?
I
So
think
the question is it by a family history? Is it by stethoscope? with an OBGYN listening? Is it out of the pediatric area? Is it by looking at the electrocardiogram? So what is your concept of that?
I think based on the based on my reading, it's a combination of all these factors. But if you're having a family history with someone with a history of Holcomb, then it's recommended that family first degree relatives are screened at the time of diagnosis of family member. So if there's a positive family history that's diagnosed at an early age, then it's recommended that there's surveillance interval screening in children and adolescents every 1 to 2 years. And then for adults with family members, it's every 3 to 5 years and screen at the time of the family member diagnosis. And then for others, it's by symptoms, a combination of EKG findings, like physical exam, and then currently this the standard for mode of imaging modality for diagnosis that I've found based on my reading is mainly echocardiography with documentations of LV wall thickness, LVL flow tract obstruction, and then history, patients' medical history. And then if things, even then after all that, if it's still uncertain, then cardiac MRI can use to confirm the diagnosis and rule out other cause of ventricular hypertrophy. But that's my general like overview of
So it seems to me that we're still missing a whole lot of these people. For example, if you take the high school football players who drop over during spring or late summer practice, my understanding is that this is not a terribly uncommon finding, hypertrophic cardiomyopathy. You know, when they go out and screen the Falcons, they find one. Well, why did they miss? Why was that Falcon missed through the years when it was all over his EKG? When Robbie and mine finally looked at the EKG and found that and said, "Oh, I know what this is." So you know, high school football players are not required to have an EKG, I don't think. So it's been my feeling that the EKG is underappreciated in this. And I would say if you have somebody coming in the emergency room with unusual looking or prominent LVH and their blood pressure is normal, then you start thinking hypertrophic cardiomyopathy. Once you get to the echo lab, you know, the diagnosis is made. But something before that, I felt like we need to be a little more astute in pursuing that diagnosis. I've seen people also who are older and who have their hip fractured, and they get in the hospital and they have the orthopedic people call you and say, well, there's a loud murmur here. Well, and then they're bleeding into the hip and they get hypovolemic, and here comes the murmur. So there are a lot of clinical scenarios that come up that have to do with EKG and the stethoscope that occur before echo and MRI and all that seemed like to me we're missing some of that. Anyway, Robbie, would you agree with that?
Yeah, I agree. You raise you really opened a lot of cans of worms there. But yeah, it's Adam's exactly right. It's a combination of things. I should make someday like a pie chart of it's some combination of someone hears a murmur, you know, like how, you know, if you were to, you know, each of these patients that we see, how was this discovered? You know, it's probably about a chunk of them in some order. And it's a pretty even distribution between, I was screened because a family member was diagnosed. Someone heard a murmur on a physical exam and that led to this. Obviously symptoms. I was getting worked up for shortness of breath and we found this. Like you said, I went to have my knee operated on, and they did an EKG on me, and they like canceled the surgery and thought I was having, sent me to the cath lab thinking I was having a heart attack. we hear that story sometimes, and it ends up being, and then, some combination of all those. The other thing you got to keep in mind with these young athletes is, or anyone, is that this disease can develop. It usually develops in young adults, but we've seen it develop in middle-aged, even older people. So, you can't always assume that it's been missed in the past. It might have just developed, within the last, whatever, 6 months or year. So, it doesn't always pop up automatically at age 18. And we've seen patients that we've been following that had no signs of disease in their 30s, 40s, and then develop it in their 50s even. So, looks like Dr. Abdu has his hand up to ask a question.
Yes, thank you, Robbie, and good presentation. Good job and a good, nice review. I have more of a comment and a question, and it kind of feeds into Dr. Clement's comment and question as well. Is that in imaging, it can be very helpful, especially if you have these typical presentations of HOCM. But we know that HOCM can come in multiple varieties. So one comment, especially nowadays with the readily available genetic testing, I think genetic testing has a role. And of course, the current guidelines mention how to use genetic testing and when to test for these. Now, the genetic testing we have commercially available, we can have a different conversation on, the controversies and the pitfalls, so on and so forth. But I wanted your opinion, Anne and Robbie, since you're on the call, to kind of comment on that a little bit. May that help and assist with the diagnosis, especially with atypical HOCM or atypical HOCM imaging findings, so on and so forth.
Sure. So I think genetic testing can be useful in that setting to help either confirm or rule out the diagnosis. But the pitfall with genetic testing is it's not positive in all patients with HCM. So we can miss a substantial portion for those who are not deemed positive. And I don't know if Dr. Williams has any thoughts regarding that.
Yeah, we'll use it. We're sort of, it's a bit of a when you get to the point where you're looking to genetic testing to help you with the diagnosis, you're sort of grasping at your last straws, because it's very expensive. It takes several weeks to even a couple months to get your results back. And as Ann said, I mean, it's at best a 50-50 shot. So a negative genetic test is entirely unhelpful, but obviously a positive genetic test will cinch the diagnosis. So yes, we will use it from time to time in those sort of borderline or atypical appearing, or really trying to tell the difference between an athletic heart and a hypertrophic cardiomyopathy or some other condition, hypertensive heart disease, or even other things. So, but we'll use it, but we try to get the diagnosis by other means.
Robbie, it's Stan again. Just commenting on what Steve had to say. I can tell you from past experience, these days, I think most of these patients, or a lot of these patients, not necessarily hypertrophic cardiomyopathy, but with just murmurs in general, are sent by the OBGYNs. They do not want to hear a murmur. It may be the most innocent murmur in the world, but they do not want to hear a murmur without having a cardiologist take over and listen to the patient and see what's going on. So I think they do a fabulous job of just saying, I hear a murmur, go see the cardiologist.
Yeah, that's true. A lot of these, and that's, like I said, that's a lot of them. A lot of women in particular, they're, when as I meet them later in life and talk to them about how they're diagnosed, it's almost like, during my first pregnancy, my OB heard a murmur, and that's how this all started. So it's a very common story in sort of how they came to be found, how they were found to have hypertrophic cardiomyopathy.
The preceding program is copyrighted by Emory University.